Hello, and welcome to today's webinar for mental health professionals, Deep Brain Stimulation for Treatment-Resistant Depression, featuring Dr. Paul Holtzheimer. My name is Susan Bailey. I'm the Senior Manager of Education here at ADAA. Before we get started, I'd like to go over a few items so you know how to participate in today's webinar. We've taken a screenshot of an example of the attendee interface. You should see something that looks like this on your own computer desktop in the upper right-hand corner. You've joined the presentation listening to your computer's audio system by default. If you prefer to join over the phone, just select Phone Call in the audio panel and the dial-in information will be displayed. You will also have an opportunity to submit text questions at any time of the presentation by typing your questions into the chat box of the control panel. You may send in your questions at any time. We will collect these and address them during the Q&A session at the end of the presentation. If you registered and paid for CE credit, you will need to provide the 4-letter CE code in the webinar evaluation. The CE code will be shared at the end of the presentation. You will receive a follow-up email including the webinar evaluation, webinar recording, and post-test assessment for those seeking CE credit. You will also have an opportunity to complete the post-test assessment after the presentation. The questions will appear on your screen and you will be given 5 minutes to complete the assessment. Once complete, please click Submit. I would now like to introduce Dr. Paul Holtzheimer. Dr. Holtzheimer is the Deputy for Research at the National Center for Post-Traumatic Stress Disorder and the Associate Professor of Psychiatry and Surgery at the Geisel School of Medicine at Dartmouth and Dartmouth-Hitchcock Medical Center. Dr. Holtzheimer's research program focuses on the neurobiology and treatment of mood disorders, primarily using functional and structural neuroimaging, as well as neuromodulation. His clinical and research efforts focus on treatment-resistant mood disorders, brain imaging, and brain stimulation therapies, including transcranial magnetic stimulation, electroconvulsive therapy, vagus nerve stimulation, and deep brain stimulation. His clinical research program at Dartmouth aims to better understand the neurocircuitry underlying treatment-resistant depression and to use this information to develop and advance novel treatment approaches, with a particular emphasis on brain stimulation therapies. I'm now going to take a moment to pass the screen to our expert, and there will be a brief pause while I do so.
So Susan, I accepted the link. I'm not, the screen disappeared. So am I just supposed to bring up my slides and present from here?
Yes, if you could bring up your PowerPoint, Paul. We can see your
Perfect.
screen.
Got it.
Great, thank you so much.
All right, I guess it's on me now. Thank you for that introduction, and thanks for the opportunity to present today. This is a topic that in many ways won't be appropriate for many patients with mood disorders because they will respond to medication, psychotherapy, TMS, and other interventions. But it is an important treatment in the sense that if it does end up becoming available, this really is a treatment for kind of the worst of the worst, treatment for people that don't respond to pretty much all other available options. It also, though, I think, and this is somewhat more important, highlights kind of a different treatment paradigm, treatment development paradigm for neuropsychiatric disorders. So rather than medications and psychotherapy, this is really employing a neural circuit paradigm, as is often used in neurology, to think about how we can target these illnesses in a somewhat different and complementary way. There we go. A few disclosures. So I do receive grant funding from the Brain Behavior Research Foundation, or NARSAD, NIH, and VA. I am a consultant with Abbott, very relevant to this talk. They are developing a deep brain stimulation intervention for depression. So I do receive consulting fees from them. Oxford University and Press and Up to Date provide royalties. I have no stock. And importantly, at the bottom here, we will be talking about an intervention that is not FDA approved for the treatment of depression. Deep brain stimulation is FDA approved for treatment of several movement disorders, as well as a humanitarian device exemption for OCD, but it is not approved for depression or any other psychiatric illness. Just so this doesn't get lost at the end, this is importantly very multidisciplinary work. And so we've had numerous collaborators between Dartmouth and Emory, where a lot of this work occurred, in neurosurgery, neuropsychology, psychology, neurology, et cetera. So multiple people have contributed to this effort. So this is very much a team approach. Very brief review. So major depressive disorder, as most of you know, is a highly prevalent medical condition. It's one of the most prevalent medical conditions, not just psychiatric conditions, but really one of the most prevalent medical conditions worldwide. In the United States, there's a 70% lifetime prevalence, and at up to a 7 to 10% one-year prevalence. And it's very costly. So it's the number one, according to the World Health Organization, number one cause of years lost due to disability, number 2 to 3 contributor to overall burden of disease. If you have depression, you'll spend twice as much on healthcare over your lifetime than if you do not. And critically, more than 60% of patients with depression rate themselves as having a severely impaired quality of life. And this is higher than you see in many other chronic illnesses across the board. So patients with depression are not only spending a lot of extra healthcare money, but they're also severely impaired in terms of quality of life. And then finally, depression is a deadly illness. So obviously suicide is often related to depression. Depression is the number one mental condition associated with suicide. But depression is also associated with an increased all-cause mortality separate from suicide. So if you have depression, you will die at a younger age than if you do not have depression. And so clearly an illness that we need to pay attention to and have appropriate treatments for. One of the challenges is that treatments for depression have really stagnated over the last 50 to 60 years. So most people may or may not realize that current medications for depression, medications developed within the last year or two, are really no more effective, no more efficacious than medications developed in the 1950s. So imipramine, which is a tricyclic antidepressant, is just as effective as the dilazodone or any of the SSRIs. And so our medication development really has not pushed the bar of efficacy at all. They are arguably safer with overdose. They are differently tolerated, and so maybe patients can tolerate them better than they might tolerate some of the older antidepressants, but the efficacy is essentially the same. And that's essentially true for our psychotherapy. So cognitive behavioral therapy for depression is highly effective as medications. It was developed, 40 to 50 years ago, and to my knowledge, the psychotherapies haven't really improved on what CBT for depression already does. Again, there are nuances in there, but the treatments for depression now are effectively about the same as they were over the last several decades. Electroconvulsive therapy, which emerged around 1938, is still the most effective treatment for depression, associated with a very high remission rate, even in patients with medication and psychotherapy-resistant depression. But as with our other treatments for depression, relapse is still a major issue. And so even ECT, as good as it is, leaves many patients inadequately treated. And when you put all these numbers together, you basically come up with a conservative estimate of 10 to 33% of major depressed patients are treatment resistant, which basically equates to about 1 to 3% of the US population. And this is important because this group of patients for whom we really don't have adequate treatments, equals the entire prevalence of schizophrenia. And so this is a very, very important group of patients with an illness that is costly and deadly that we really don't have adequate treatments for. I mentioned at the beginning that there are different treatment paradigms for developing interventions for neuropsychiatric disorders. These broadly fall into behavioral paradigms that kind of lead to our psychotherapies, chemical paradigms that lead to the development of medications, and this really falls into this group of treatments, focal brain stimulation, fall into a third paradigm of neural circuit or neuroanatomical interventions. So this is thinking about the illness in terms of the brain regions involved in the disorder, how they're connected to each other, and how they need to communicate with each other to regulate mood adequately. And so it's not as much focused on what are the neurotransmitters driving that communication, but more how are these brain regions sort of talking to each other, what turns one region up versus another down, and how you might intervene in that to treat the disorder. What you need to do this is pretty similar across disorders. You have to delineate the neural circuitry, and so this currently uses brain imaging to map out in vivo the brain regions involved in the disorder and how they are communicating with each other and how that changes with effective and ineffective treatment. Through this, you can identify key nodes that might be sort of targets for intervention. And then you can think about what could brain stimulation do to affect these nodes. Could you activate them? Could you inhibit them to sort of change the network activity? And this is by no means a new concept. So this actually predates medications by several decades. Many people may be familiar with Pape's circuit. This is an image from 1937, but the actual concept goes back to the late 19th century. And it was hypothesized that severe neuropsychiatric illness emerged from dysregulated flow of information from midbrain subcortical regions to the cortex. So you'll see in this figure you have kind of lines going from the thalamus and cortical or subcortical regions out to the cingulate gyrus, the orbital frontal cortex. And the thought was there's too much flow of information. It was not being adequately regulated by the cortex. And so the thought was, well, one way to intervene therapeutically would be to cut those connections. And so this led to effectively the prefrontal leucotomy or the prefrontal lobotomy, euphemistically labeled here as orbital undercutting. And this was pre-imaging days. And so basically you would stick a probe into the orbital frontal cortex, you would sever these white matter fibers and see if you had a beneficial effect. Obviously, we don't do this anymore, and the reason is it had significant side effects of seizure disorders, personality changes, cognitive changes. But what we often don't talk about with the prefrontal leucotomy is that in many cases, there were actually clinical benefits. So patients with severe OCD, for example, might be less affected by their symptoms. Patients with severe depression or catatonia might be more responsive and less depressed. And so the thought was, well, we're getting some benefit, but we're getting a lot of side effects. Maybe we need a more focal lesion, which would make sense. And so over the years, various approaches were tried. Yttrium subcaudate tractotomy was basically placing a radioactive bead in the brain and making the lesion essentially inside out. And then importantly, in the 1940s, 1950s, there were developed stereotactic neurosurgical techniques. And so this is the image on the top right. This is basically using brain imaging to put the brain into a three-dimensional space that would allow you to very precisely target at the millimeter to submillimeter level where you would want to place a lesion. Many neurosurgeons don't even realize that the birth of stereotactic functional neurosurgery was actually to do a better lobotomy. It was not to treat Parkinson's and tremor. It was actually to do a better prefrontal lobotomy for psychiatric patients. These interventions still essentially exist today in terms of subcaudate tractotomy, capsulotomy, and cingulotomy. These are still available for patients with very severe treatment and refractory illness. The data is all open label with no good controlled trials, but those data, again, as with the early lobotomy, suggest some efficacy, anywhere from 22% on the low end to 75% on the high end of symptom benefit from these interventions, and yet they are still associated with significant side effects, seizure disorders, personality changes, and neurocognitive deficits. And so the question is, what can we do to make this better? Again, not throwing out the idea completely, trying to build on the efficacy we have and trying to achieve the efficacy without side effects. To do this, we actually need better neural circuit diagrams. So this very simplistic subcortical to cortical information flow is probably way too basic. And we now have potentially methods to develop better systems or better models. And we need better methods to intervene. And so when you make a lesion, you take out brain tissue, you're not allowed to get it back. And so the idea is, are there better ways of intervening in these circuits that don't have the permanent side effects that a lesion might have? Again, brain imaging over the last 30 to 40 years has revolutionized this approach, allowing us, again, to look at the brain in vivo, both at rest and in various tasks, to look at the brain pre-treatment to post-treatment to see what changes. And from this, so this is a figure from Helen Mayberg, who is my mentor at Emory, now at Mount Sinai, who really was one of the pioneers in this field. You can develop effectively circuit diagrams. So you have dorsal regions at the top, you have regions involved in mood regulation and mood monitoring, and then very subcortical ventral regions involved in interoception, autonomic states, circadian rhythms, et cetera. And from imaging studies, you can then show potentially where various treatments are working. So cognitive behavioral therapy, for example, can be shown to seem to be operating to more of a top-down mechanism. Medications seem to be operating from more of a bottom-up mechanism. But then most importantly, you can then identify, again, these key nodes that seem to be associated with and drive treatment response. And so circled at the top here, the prefrontal cortex, Broadband area 46-49 is a target for transcranial magnetic stimulation. The medial frontal cortex has also been a target for transcranial magnetic stimulation. And then you have regions such as the ventral striatum, the medial forebrain bundle to the ventral tegmental area, subcallosal cingulate and brainstem that also seem to be critical to response. But because of their location deeper in the brain, you can't hit these with transcranial magnetic stimulation. You really need something that can get deeper into the brain, and that would be deep brain stimulation. For the rest of this talk, we will mostly focus on the justification for and the work with the subcallosal cingulate, but we'll touch on some of the other brain regions as well. So this region became of interest to Dr. Mayberg, Helen Mayberg, as she was putting together kind of all the brain imaging studies out there, the converging evidence, showing that if you made healthy people sad, you actually saw an increase of activity in this area. Similarly, if you took previously depressed patients and you made them transiently more depressed with tryptophan depletion, it's a way of taking out the precursor to serotonin temporarily, and patients who have previously responded to a serotonin reuptake inhibitor will show a transient increase in depressive symptoms, you also see increased activity in this area. More importantly, when you look across treatment studies and you see what changes consistently in patients who get better with antidepressant interventions, you see that across SSRIs like venlafaxine, or SSRIs like fluoxetine and sertraline, SNRIs like venlafaxine or duloxetine, even placebo, TMS and ECT, a very consistent change is decrease in activity in this subcallosal cingulate area. So it goes up when people get sad, and it goes down when patients with depression get better. And then finally, when you look in more detail at the connectivity of this region, you can show that it's increased in people with treatment-resistant depression, and its connectivity is actually disturbed in patients with treatment-resistant depression, leading to sort of the question of, what is the connectivity of this region and how is it involved in this circuit? Purely from an anatomical standpoint, so that the previous slide was really talking about functional activity of this region, but purely from an anatomical standpoint, you can see that this region is monosynaptically connected to multiple other brain regions involved in the neural circuitry of depression, the medial frontal cortex, the cingulate, the hippocampus, the hypothalamus, the amygdala, making it effectively a central node in this network. So not only does it seem to be a key node functionally in terms of mood regulation or sadness, it also appears to be a central node structurally, making it a very attractive target for potential intervention, and suggesting that treatment-resistant depression may actually be at least a subset of treatment-resistant depression, maybe due to dysregulated connectivity of this region. So again, this region is deep in the brain, cannot reach it via TMS. And so the question is, how do you reach it? And the answer is DBS. So deep brain stimulation has largely replaced ablation in the field of treating mood disorders, so for Parkinson's disease and tremor. Effectively, with deep brain stimulation, you have an electrode that's implanted in the brain. It's about 1 centimeter long with 4 individual contacts that can be used for stimulation. You can stimulate at one contact, you can stimulate at multiple contacts. Each of those is about, with the device we're using, each of those is about 1 millimeter wide and 1 millimeter long. That is implanted, again, via stereotactic neurosurgical techniques. So in the operating room, deep into the brain to whatever target you're trying to reach. There are then wires connecting it, the DBS electrode, to a pulse generator or battery in the chest wall. These are all subcutaneous, so the system is completely internal. And then you can communicate with this battery via an external wand that allows you to change the parameters, the intensity of stimulation, the frequency of stimulation, whether you want to stimulate chronically versus intermittently, et cetera. This is the subcallosal cingulate target, and so you have kind of a few images here from different angles, with the bottom images showing post-operative CT scan of the electrode superimposed on the MRI. And this is important because we can then use this to pick which contact we're going to use to stimulate in that patient. It also means that if the first contact we choose doesn't work, we can look at the image again and see if there's a different contact that we think might be a good option as a second. This also highlights, and we'll come back to a bit later, that even though this electrode is only 1 centimeter from top to bottom, you can see how each individual contact really is in a very different white matter region. So stimulating over that centimeter, just changing it by a couple of millimeters within that completely changes the parts of the brain that you're actually stimulating and what that region is connected to. So with all of the preliminary work that Helen had done, sort of putting these imaging studies together, worked with Anders Lozano and Sid Kennedy in Toronto to do the first pilot studies of this. This work was conducted in the early 2000s, with the first publication coming out of Neuron in 2005, proof of principle in 6 patients, eventually enrolling up to 20 patients. And again, to be clear, these patients are, as I said earlier, the worst of the worst. So these are patients who have failed, on average, 6 to 12 medications in their current episode. Most had failed ECT, all had tried and failed psychotherapy. And so these are patients where, when you see them clinically, you literally have no treatment options to suggest for them that are at least FDA approved or evidence-based. And so in these patients, for whom you'd expect a 0 to 10% spontaneous remission over time, in this early open label study, saw a 60% response rate. So that's a 50% decrease in symptom severity at 6 months, 55% response rate maintained at 12 months, and then when you looked long term, you actually saw a 64% response rate at 3 to 6 years. So these are very high response rates, much higher than you would expect to see with treatment as usual. And importantly, seeing this response in the absence of acute or chronic stimulation effects and no negative neurocognitive changes, so no neurocognitive deficits associated with the treatment. So this was very, very encouraging work. Helen then moved to Emory. I moved to Emory, and we did effectively a replication of this study. A couple of changes we did to just add to the picture. It's still an open label study, but we did include bipolar II depressed patients. And we also included a 1-month sham lead-in to sort of begin to evaluate for a sham effect. Again, patients had to be depressed for at least a year, so approaching chronic depression, had to have at least 4 medication failures and failure of ECT to get into the study. We allowed patients to stay on their medications through the study, so this is really an adjunctive or augmentation treatment. And then once they were implanted, our a priori endpoint was 6 months, and then we followed them naturalistically after that. Here you see a figure from our paper out to 2 years, The dark blue are patients who are moderate to severely depressed. The royal blue are patients who have mild depression. The light blue, patients with remission. And so you see this steadily increases over time. So there is a very small sham effect. So we did actually see some insertion effect or sham stimulation effect potentially over the first month, but then you see a considerable increase in efficacy over time. At our 6-month a priori endpoint, we had a 18% full remission rate, 41% response rate, and then saw these steadily increase up to 58% and 92% respectively for the patients out to 2 years. And I'll show you another even longer term figure of this a little bit later. Critically, and in comparison to ECT, TMS, medications, and psychotherapy, no patient achieving relapse over the time frame that we followed them, no patient achieving remission relapsed over that time frame. So these are patients who, if they got well, continued to stay well over time as long as stimulation was continued. And that's an important point. So initially in the study, we had a phase where we would actually discontinue treatment in patients in a blinded way. So we would tell patients that stimulation might be on versus off, but everybody got turned off. And the 3 patients who underwent this phase, you can see they all improved over the 24 weeks or 6 months of open label stimulation. And with discontinuation within 1 to 3 weeks, all of them returned to their baseline depression severity. And then when we turned it back, the stimulation back on, then they improved back to their previous improvement levels, if not further with extra time. So again, patients, if they get better, they tend to stay better, but it requires ongoing stimulation. And if you turn off the stimulation, and we've seen this when patients' batteries become depleted, if the device inadvertently gets turned off by a sort of proximity to a magnet, then the same thing happens. So virtually 100% of patients, when you turn off stimulation, will have a return of depressive symptoms. So as I said at the beginning, this is just one of many potential targets for brain stimulation or ablation. This is a figure just sort of highlighting several of the others. Again, all kind of in the neural circuitry of depression or other neuropsychiatric conditions. One of the regions that was targeted about kind of in parallel with the subcallosal cingulate was the ventral anterior internal capsule, ventral striatum, by a group at Brown, Massachusetts General Hospital and the Cleveland Clinic. And so they did a pilot study of 15 patients, again, open label, very similar very similar demographic and clinical characteristics as our patient population, and reasonably similar response rate. So a 40% response rate at 6 months, which is pretty similar to what we saw, and then a good long-term response rate as well, about 53%. Parameters about the same as what we used. Different from the subcallosal cingulate target, stimulation in this brain region was associated potentially with acute stimulation effects, so either involuntary smile, autonomic effects, anxiety attacks, etc. But nearly all of those could be made to go away with stimulation adjustments, and there were no adverse effects of long-term stimulation. So those were not permanent. And as with our study, they showed no significant changes in neuropsychological functioning over time. The deepest part of that region of the ventral capsule, ventral striatum, is the nucleus accumbens. Thomas Schleffer and his group in Germany targeted that region specifically with the hypothesis that since anhedonia is a major kind of core symptom of depression, perhaps stimulation in this brain region, nucleus accumbens, that had been associated with reward circuitry might actually target that symptom cluster specifically in depression and lead to overall improvements in the disorder. Again, an open label study of 11 patients, again, very similar inclusion criteria as we used, very similar stimulation parameters, actually had similar acute stimulation effects as the previous target, the ventral capsule, ventral striatum on the previous slide, and for the most part, similar good response rates, again, better than you would expect to see with treatment as usual. And again, no long-term side effects and no cognitive impairment. This same group then chose a even more upstream target, so the medial forebrain bundle, which is the white matter connecting the ventral tegmental area, which is largely dopaminergic, to the ventral striatum, and also kind of core to reward circuitry. And so they use diffusion tensor imaging, which is an MRI technique to look at the brain's white matter, to identify this white matter bundle, and then placed an electrode there. Again, this is sort of upstream from the nucleus accumbens in the ventral striatum. And they, again, open label, found very good efficacy. And different from the earlier studies. So you remember from the study of the subcallosal cingulate, and it was also true for the ventral capsule and the nucleus accumbens, patients did get better. So roughly half of the patients are having significant improvement, but it often took weeks to months to see that improvement. In this initial study of the medial forebrain bundle deep brain stimulation, they actually saw these improvements within a few weeks. And so this is a very rapid improvement. There's been a longer a controlled trial of this that's potentially less impressive, but it's still a treatment that needs to be validated. But if this holds, then this would actually be very encouraging, because then you could get patients well quickly. And again, they seem to stay well over time. So in all of this, we have studies of 3 to 4 brain targets, all of them showing very encouraging results in very ill treatment-resistant patients. And so companies were basically chomping at the bit to try to develop this treatment and get it FDA approved and get this onto the market. And so these studies were conducted, and we've had a bit of a hiccup. So the first target that was studied was the ventral striatum target, the ventral capsule ventral striatum target. This was a planned to be a large pivotal phase 3 randomized controlled trial. The control condition here is leaving the stimulation off. So basically patients are randomized to on versus off stimulation, and then followed over time. Their endpoint was at 16 weeks. The FDA required them to do an interim analysis after the first 30 patients. And when they did that, they effectively saw no difference between active and sham stimulation. So then they halted the trial. And to my knowledge, they've not continued investigating in that area. And then we had the subcallosal cingulate target. So this was a company called St. Jude Medical. They're now Abbott. Again, I'm a consultant for Abbott currently. Helen Mayberg and I were heavily involved in helping to design this trial and kind of monitoring it scientifically during its conduct. It was designed as a multi-site randomized trial with 2-to-1 randomization, so 2 to active versus 1 to sham. It was double-blind with a 6-month blinded phase, and then a 6-month open label phase, and then long-term follow-up. Recruitment over about 4 years. And as with the ventral capsule, ventral striatum study, we had sort of a look at the data in the middle. We didn't do the first 30 patients, which the FDA asked us to do initially. We actually were able to agree upon a planned futility analysis once about half the patient population was recruited. To be clear, this didn't technically fail the futility analysis, but we'll see the results in a moment. It was not very encouraging. And importantly, this study, in terms of the demographics and clinical characteristics, was very, very similar to our previous open label studies. So in terms of age, gender distribution, levels of severity, history of suicide attempts, et cetera, level of treatment resistance, it's a very, very similar group. The one area that was notably different in this sample from our previous studies was the duration of current episode. Again, all of these patients in all of these studies have been chronically depressed with an average duration of current episode of around 4 to 6 years. But in this study, the average duration of current episode was about 10 years. So this is a much more chronically depressed patient population than we had enrolled previously. And so even though everything else seemed to be relatively similar, this was an important difference that we noted. And again, as I said, so technically it didn't fail the futility analysis, but it's harder to see a figure of a more negative study than this. And so effectively, parallel lines between sham and active stimulation. The red line is the control group, the sham group, the blue line is the stimulation group. And you see that these lines effectively are parallel throughout the blinded phase and continue to remain parallel during the open label phase when all of the sham patients also got turned on. So the question then is, what happened? How did such an encouraging study, early open label studies, lead to a completely negative randomized controlled trial? So the important question in all of these studies is always, do you have the wrong patient? So in our prior studies and in the double-blind controlled studies, no clear association of response with age or gender. Importantly, no association with treatment resistance. So just because you'd failed 20 medications versus 4 didn't make you any more or less likely to respond to the treatment. Comorbidity is a predictor of treatment resistance with medications and psychotherapy and ECT. We don't really know the effect of comorbidity in this cohort because we effectively excluded patients with other psychiatric illnesses. So these are patients with major depressive disorder, but without clinically significant OCD, PTSD, et cetera. So we don't really think that, we know that that didn't have an effect. What we don't know is whether there were more subtle, say, personality disorder, characterologic characteristics that might have contributed to different patient populations. But again, we didn't really assess that in a way that would allow us to answer that question. The main question we had is this difference in duration of current episode of about 10 years versus 5 years important? And one of the things we found in our earlier study at Emory was that, and this may relate to duration of current episode, is that patients who had periods of wellness throughout their illness, so periods of time since their first depressive episode where they would go months or years without a depressive episode, those patients actually responded really well, often responded more quickly. And that actually might have been an important criterion for inclusion that we didn't use for the double-blind study, but that we might suggest for a study going forward. So there's a possibility that the patient population here was not ideal for testing this intervention. Then you always have to think about placebo effect. So when we designed the trial, we sort of estimated what the placebo effect might be. We actually had many experts weigh in on this and sort of decided that about a 20% placebo response rate is probably the most we would see. And we were pretty much correct. So the sham response rate in this study was only about 17% at 6 months, which was very close to our predicted 20. So we really didn't think placebo had an effect here. So again, the difference in this study versus the earlier studies wasn't a strong placebo effect, as we sometimes see in depression treatment studies. It was actually not having as much of a benefit in the active group, which again, may be due to the patient population or another feature. One of the most important things to consider in deep brain stimulation studies, and also other brain stimulation studies like TMS, is, are you actually hitting the correct target, or did we miss? And so we've now gone from pilot studies at a single site to multi-center studies at 10 to 15 sites, and so a lot of different neurosurgeons with more or less experience with this intervention. And so the question is, did we sometimes miss? We looked at the data. So this is the data actually from an earlier Toronto study showing that location matters, and you have to be in this region to get benefit. But when you look at the responders versus the non-responders, just in terms of gross anatomical location, broadly speaking, it didn't look like location mattered that much. This was true at our Emory study as well, that when you compared the location of stimulation for non-responders versus responders, again, it roughly seemed to be in the same place in a gross anatomic way. When we look back at the study, the double-blind controlled study, same thing, that there didn't seem to be an obvious difference in the location of the stimulation target in responders and non-responders. However, and this is going back to that image of the CT scan superimposed on the MRI, there is subtlety here. So even if the electrode is roughly in the correct place, you can see that the contact you're using for stimulation is targeting very different white matter bands and therefore targeting very different parts of this network. So the regions connected to this target are different depending on which contact you're using for stimulation. And we know that the benefit isn't just stimulation, isn't just effects at the subcallosal cingulate. We know from earlier imaging studies, the benefit is associated with a network level effect. So changes in medial frontal cortex, posterior cingulate cortex, orbital frontal cortex, et cetera. And one of the key differences one of the key findings in patients who get better being this decreased activity in the medial frontal cortex, which again is one of the regions directly connected to the subcallosal cingulate target. We were starting to figure this out as we were enrolling some of our last patients in the initial Emory study, and we actually had one patient who was a great candidate overall. She had recurrent depression, she had periods of euthymia, and we thought she was going to be a great responder. We implanted her, and you can see on the figure here that when we think about this white matter region that's going out to the medial frontal cortex, she does seem to have an electrode in that region, but it's not very solidly placed in that region. Over time, with stimulation, she did get a bit better, about 30% improvement. But as soon as she reached the 24-week endpoint, she rapidly got worse again. She sort of realized she wasn't really as better as she thought she was, that she was trying to be hopeful. And so she was a non-responder and effectively became a very minimal responder. But because we looked at these images and said, well, we don't really have a contact in this white matter region that we think is really important, we offered her the opportunity to be reimplanted so that we could place the electrode deeper into the brain so that we would have a contact in that white matter band. So we did that, and then we actually did DTI to confirm that. So the first contact is in blue. After the surgery, a second surgery, the contact used for stimulation is in red, and this is a DTI tractography. So again, this is using an MRI-based imaging technique to look at white matter and basically draw out the white matter tracks emerging from, or sort of kind of projecting from, the region of stimulation. And you can see that the contact used for the first, after the first surgery, really didn't get out into this medial frontal band at all. Did get up into the anterior cingulate, but after the second surgery, the contact very clearly gets out to the medial frontal cortex. And then with stimulation, she went into remission within a few weeks and remains in remission today. She's now married, has a job, I think she has kids. And so this was a good proof of concept demonstration that it doesn't, being in roughly the same place isn't enough. You really have to be targeting the appropriate white matter tracks. To be very clear, the difference in contact location from surgery 1 to surgery 2 is about 1 millimeter. And so we're talking about very, very subtle differences in location that have significant impacts in terms of which white matter regions you're actually able to target. We then validated this in the whole group by looking at DTI of responders versus non-responders, again showing that responders had much stronger projections out to medial frontal cortex. In this sample, actually even stronger projections to cingulate compared to non-responders, and down into the ventral striatum and thalamus. And so even though we knew that this medial frontal region was important, we also were identifying other white matter tracks that needed to be potentially targeted as well. And that led us to basically hypothesize effectively a tract map that had to be targeted. So the target for the stimulation is still the subcallosal cingulate, but you need to be in a region of the subcallosal cingulate that adequately impacts some of these core white matter bands. So forceps minor getting out to the medial frontal cortex, uncinate fasciculus down into the amygdala hippocampus, cingulum bundle, and then down into the ventral striatum. So using this concept, we then conducted a prospective study using DTI-based targeting. So before we would just say, we need the contact in the subcallosal cingulate. Now we're basically looking at the DTI tractography preoperatively, moving around potential targets on the computer screen until we get a target that generates the tract map that we know we need to get from the previous study, and that becomes the target for stimulation. And so Helen Mayberg and Patricio Rivapose, this is after I was involved, but I'd left for Dartmouth by then, did an open label study in 11 patients, and compared to our 18% remission rate and 41% response rate in the first pilot study, they were now getting a 73% response rate and a 55% response rate at 6 months with this prospective targeting. Again, major caveat, this is open label, not placebo controlled, but very encouraging that by this more nuanced type of targeting, you might be able to get much better outcomes. And again, this was not a procedure we used for targeting in the double-blind placebo-controlled studies, so it sort of adds to, if we were to do a study again, here are some of the changes we would make. So we might change the patient population to be either less chronically severe chronically depressed patients, or at least patients with history of euthymia between episodes, and in terms of targeting, using DTI prospectively to identify the kind of the white matter tracks that we want to be in. Final thing we'll talk about is design. And so these studies had a 6-month endpoint and then long-term follow-up. It may be that 6 months is too early. So even in our early study, there was clear open-label benefit at 6 months, but then benefit continued to accrue over time. Same is true for the quote-unquote failed double-blind controlled studies. So these patients, again, there was no separation between active and sham at 6 months. Then everybody was turned on. But then when you looked from baseline of active stimulation to 24 months of active stimulation, you see a consistent improvement over time, with around 50% of patients eventually becoming treatment responders. And then from our earlier, from the 2 early pilot studies at Emory, so the one of 17 patients and then the prospective targeting patients, when you put all of those patients together, we now have data out to 8 years for nearly all of them. And again, showing that 6 months is early in this diagram, right? And so you don't get a plateau of response until about 3 years. And again, once you get response, it appears to be maintained over time. So the question is, is 6 months too short? And the problem is, doing anything longer for a placebo-controlled trial is really, really difficult to do. However, we do know, or we think we know, that stimulation is required for benefit. And if you turn it off, patients can get worse. And this is true for our target, but it's also true for other targets. And so a group in the Netherlands conducted a study with a very different design, kind of flipped the randomized controlled trial on its head, and everybody got open label stimulation for out to a year, give or take. And only at that point were patients randomized to on versus off stimulation. For patients that had very little improvement over the year of optimization, they showed very little change whether you turned it off versus left it on. So for patients who didn't really respond to treatment over the year, they didn't have any effect of turning it off. However, for patients that did show a response over the year, you saw a very clear difference when you turned it off versus left it on. So again, suggesting that maybe there is a different way to test these devices that may require months and months to optimize the intervention rather than the typical 3 to 6 month trial that we're used to in depression studies. So next steps is to think about alternative designs for pivotal trials. We're not giving up on this yet. Use the data we do have to think about how we might modify the inclusion criteria, the targeting methods, et cetera. And then I didn't talk much today, but we have a whole nother line of research that's looking at the neurobiological mechanisms of this through electrophysiology, brain imaging, et cetera, to see if we can develop biomarkers for who gets better, who doesn't, or ways to use electrophysiology or brain imaging to help tune the devices to get better effects. So with that, I will stop. We have about 10 to 15 minutes for questions, and so I will either turn it back over to Susan, or Susan, you tell me how you want to handle this.
Well, thank you so much, Dr. Holzheimer. Yes, we'd like to take questions about today's presentation. And as a reminder, you can still submit questions through the chat box in your attendee control panel. So if you'd like to ask a question, you can do so now. Okay, well, it doesn't appear that we have any questions. So I would like to thank you, Dr. Holzheimer, and thank you to our participants for attending today's training. Oh, I'm sorry, we do have a question. Right. We do have a question.
Okay.
Yeah, so the question is, can this be used for patients with moderate depression, or would it only be effective for severe treatment-resistant patients?
It's a very interesting question, and I think at the current stage, the studies will probably continue to include only patients with severe, well, there's two issues here. One is how you define severity and depression, and the other is which patients are appropriate for the intervention. Very quickly, there are kind of different ways to think about severity and depression. You can either have somebody with very severe depression, meaning that they have very high scores on symptom severity scales, like the Hamilton Depression Rating Scale or the Beck Depression Inventory, and so they're highly, highly symptomatic. And then you could have severity in the sense that patients may not have high symptom severity, but they are chronically impaired and ill. And so the latter is mostly true for our patients, that on the Hamilton Depression Rating Scale, many of them were more in the moderate to moderate severe range, not at the very highest severe levels, but they were at that level despite multiple treatment attempts. So they had a different sort of concept of what severity was. So that is sort of precursor. In terms of which patients are appropriate for this intervention, at this stage, the patients will probably continue to be patients for whom there really is no other evidence-based intervention. So they've gone through medications, they've been offered at least ECT, they've hopefully gone through psychotherapy, cognitive behavioral therapy. However, over time, that could potentially change if we were able to identify, say, a biomarker that said, if you have this blood level of an inflammatory marker or you have this brain imaging finding, then you are extremely unlikely to respond to available treatments. It could be that deep brain stimulation might be offered to that patient at an earlier stage of illness. We are many, many years away from that, and so I don't think that's a reality anytime soon. But we've actually seen this in other disorders. So, for example, in epilepsy, for example, standard of care for like mesial temporal lobe epilepsy is to be evaluated for surgical treatment prior to having years and years and years of medication, because surgical intervention can be curative. It could be that someday either DBS or another surgical implanted device, if it showed consistent benefit with low relapse rates over time and effectively appeared to be curative, it might be that we would offer it earlier in the illness. But again, I think that's effectively years away.
Okay, thank you so much. We do have some more questions. The next question is, how long do you try TMS before moving on to deep brain stimulation?
So the TMS studies to date have included, so I'm going to answer that question two slightly different ways. So the first is comparing the two studies, the two treatments in terms of studies of them. TMS studies to date have largely included, almost exclusively included, patients who have failed no more than 3 or 4 antidepressant treatments in the current episode. Whereas the deep brain stimulation studies to date have only included patients that have failed at least 4 medications in the current episode, and usually average around 6 or 7 medication failures in the current episode. So these are just qualitatively 2 different patient populations in terms of quote-unquote treatment-resistant depression. So that's one thing to keep in mind. The second is obviously the invasiveness is much different. So TMS is non-invasive and very, very low risk. DBS is highly invasive. You're putting an electrode in the brain, and relatively low risk in terms of as far as neurosurgery goes, but there is still the risk of stroke, et cetera, with the surgical procedure. Excuse me, the risks are low, but they're much higher than they are with TMS. So TMS is something that we would consider using at a relatively early stage of illness. So if a patient had failed 1 or 2 medications, we might suggest or recommend a course of TMS. If DBS, say, was approved for depression and available, we would probably say you should try at least 3 or 4 other treatments. Try some augmentation strategies with medications, definitely try psychotherapy, probably try TMS, possibly try ketamine, before we would say that the risk of the intervention is outweighed by the potential benefit. That's the current stage. But again, as to the last question, there might come a day where we'd consider it earlier on. But I would say TMS would be considered very early on in the course of treatment. DBS, if it was available, would be much, much farther along in the person's illness history.
Thank you so much for that answer. We do have another question. Have there been any studies with DBS response and differences in genetic polymorphisms related to serotonin and dopamine?
So we collected that data at Emory. We did not collect it as part of the double-blind trial. We wanted to, but the company did not want to pay for it. We collected that data, but because the sample size was so small, we didn't see any differences. That doesn't mean there isn't a difference there, but you really need fairly large groups of patients, cohorts of patients, to actually see improvement. So we found between the responders, non-responders, there was no obvious difference between, say, the short versus long allele of the serotonin transporter polymorphism. Ideally, if we did a second larger pivotal study, we'd be able to collect that data. But currently we have the data, but currently it's non-conclusive.
Okay, very good. One last question. Do you remove the implants in people that do not respond to the treatment?
Very good question. So for patients, we always offer to patients that for any reason at all, we are happy to remove the device completely. And the nice thing about deep brain stimulation compared to ablation is that when you take it out, you effectively leave nothing behind. So there's no lesion, there's no device that stays in, et cetera. For patients, we have removed the device in patients who've had no response to the treatment and they've asked for it to be taken out. There are patients who've not responded to the intervention who've chosen to leave the device in with the hope that over time we might identify different ways to use stimulation with the device to achieve a benefit. We've also had, interestingly, patients who have actually shown a response to treatment who have chosen to have it taken out and have actually had some recurrence of the depression, but then have chosen not to have it put back in. I can't explain or I'm not going to go into the detail of those specific cases, but so we definitely have taken it out. Mostly that's been due to patients who haven't responded, but occasionally we have taken it out for patients who have had at least some response. Rarely I don't think we've ever had a patient who's had full remission who's chosen to have it taken out. And then to be clear, prior to taking it out, we would actually turn it off and see if there was any worsening of symptoms. And only after a period of off, like usually a month or two, if not more, would we then sort of go ahead with explanting the device.
Okay, terrific, thank you. We are getting some great questions, and we have another one. Did you examine any environmental differences between responders and non-responders, as in the current or early life exposure to traumatic events or poverty and maltreatment, et cetera?
Yeah, so again, we did collect that data. So, at Emory, a big focus of their research, especially when Charlie Nemiroff was chair there, was looking at effects of early life stress on mental health and emotional development over time. And so just being in that environment, it was just natural to collect information on early life trauma, total life traumas, et cetera. As with the genetic question, the answer is we had the data. The data did not clearly demonstrate any difference between responders and non-responders in terms of early life stress or total stressful life events. Again, that doesn't mean that there isn't an effect. It's just that if there is an effect, it's small enough that in a small sample, we were not able to see it.
Okay, well, thank you. That concludes our questions. I want to thank you again, Dr. Holzheimer, and our participants for attending today's training. You will receive a follow-up email shortly that includes the link to the webinar evaluation, webinar recording, and post-test assessment for those seeking CE credits. Please stay on the webinar platform if you'd like to take the post-test assessment after a few announcements.
Great, thank you very much.
Thank you. So I'd like to share that if you're not yet an ADA member, we invite you to view the many membership benefits that ADA has to offer. ADA members enjoy year-long access to continuing education programs, free access to special interest groups, including online peer consultation groups, promotion of your practice in ADA's online Find a Therapist database, significant discount to ADA's annual 4-day conference, website listings of your clinical trials, support groups, and publications, free online access to Depression and Anxiety, ADA's official research journal, networking and collaborating with experts and colleagues from around the world, and much more. Please visit adaa.org to learn more. We'd also like to invite you to register for our upcoming webinar in April 23rd, when speaker Mike Heady will be presenting on distinguishing suicidal ideation from intrusive self-harm, OCD. We'd also like to invite you to register for ADA's annual conference, March 19th to March 22nd in San Antonio. So on behalf of ADA and our presenter, we'd like to thank you for joining us today.